Hello, my name is Mary Mitchell, and I will be doing my webcam presentation on a 77-year-old Hispanic male presenting with left facial droop and slurred speech. Chief complaint. Patient was eating breakfast with his friends when they noticed a sudden onset of left facial droop and slurred speech. The patient's friends called the patient's daughter and she brought him into the hospital for further evaluation. History of present illness. The patient presented to the hospital with left facial droop, left arm and left leg weakness, a left gaze preference, dysarthria, aphasia, and left-sided neglect. Onset was approximately 9 a.m. in the morning. Patient presented to the emergency department at about 10:15. Past medical history. Patient's past medical history is positive for hypertension, type 2 diabetes, hyperlipidemia, and GERD. Patient's social history. He is retired and lives with his wife in a one-story home. He reports that he quit smoking and drinking alcohol 15 years ago. Patient's home medications are as follows: Nadolol 20 milligrams PO daily, aspirin 81 milligrams PO daily, Januvia 100 milligrams PO daily, Simvastatin 10 milligrams PO QHS, omeprazole 20 milligrams PO BID, ascorbic acid 500 milligrams PO daily, lisinopril 2.5 milligrams PO daily, Cinna 8.6 milligrams PO daily, and vitamin B12 1,000 micrograms PO daily. The patient does not have any drug allergies. Review of systems. Patient denies any fever, chills, or headache. HEENT. Patient does report difficulty swallowing, but denies any visual loss. Neuro. Patient does report difficulty speaking, reports he has left-sided weakness, but denies any loss of sensation, any headache, or any loss of consciousness. Let's see. Musculoskeletal. Patient does report that he has the left-sided weakness, but doesn't have any loss of range of motion. Physical exam is as follows. Vital signs. Temperature is 98.6 oral. Heart rate is 66. Sinus rhythm. Respiratory rate is 14. Blood pressure 170 over 74. Oxygen saturation is 100%. General, this patient is a pleasant 77-year-old Hispanic male. His son is currently at the bedside. He appears to be well kept, but he's having difficulty sitting up. He's wanting to lean over to the left side, and he does have the obvious left gaze preference. HENT, his pupils are 3 millimeters round and bristly reactive to light. He has no palpable masses or nodules on his head or neck. Like I said, left gaze deviation is noted, but the patient's eyes are unable to cross midline. And there is bilateral left visual field cuts noted. Neurologically, the patient is oriented to person, place, and time. There is no decreased sensation noted to the left side. The left arm strength is 0 out of 5, but he does withdraw minimally to noxious stimuli. Left leg strength is 1 out of 5. The patient is noted to have moderate to severe dysarthria, but mild aphasia. Likewise, musculoskeletal, same thing. Left arm strength 0 out of 5, but he does withdraw minimally to noxious stimuli. Left leg strength 1 out of 5. No deficit is noted to the right. Right arm and leg strength is 5 out of 5. Labs are as follows. WBC is 6.4, H&H 12.5 and 37. Platelet count is 87. PT is 13.6, INR 1.01, PGT 32.3. His glucose is 159, sodium 140, potassium 4.2. BUN and creatinine are fine, 15 and 0.96. His serum osmolality 309. He did have some imaging studies done. Chest x-ray was unremarkable. CT of the head, however, did show a 2.5 centimeter right frontal lobe intracerebral hemorrhage. So, assessment. Number 1 is the intracerebral hemorrhage. His ICH score was 0, though. Number 2, hypertension. Number 3, thrombocytopenia. So my plan is as follows. We're going to admit him to neuro ICU, neuro checks Q1 hour, and report any decrease in neurologic exam. Vital signs will be per the ICU protocol, so that's every hour, or more often if they're on any infusions to maintain blood pressure within a certain range. For him, we want to maintain a systolic blood pressure 100 to 150 millimeters of mercury. We're going to do a mannitol 1 gram per kilo loading dose, then 0.5 gram per kilogram Q6 hours, and we'll hold if his serum osmo goes above 320. We're also going to start 3% saline infusion for brain edema, and it'll be the low goal protocol. We'll do serum sodium and serum osmo checks Q6 hours. Prophylactic Keppra 500 milligrams IV Q12 hours to prevent seizures since he does have an ICH. We'll insert a central line for the IV vesicant medications. I'd like to draw a peripheral blood smear and hepatitis panel. Consider consulting hematology and do an iron panel as well for the thrombocytopenia. Daily CBC, BMP, MAG, PTINR, PTT. We'll do a repeat CT scan in 6 hours, make sure the hemorrhage hasn't grown or we don't have any mass effect or cerebral edema going on. We will consult neurosurgery for possible craniotomy or EVD placement in the future, especially if the patient does have a decrease in neurologic status. Goal is to keep the patient euvolemic, normoglycemic, and normothermic. So we will do glucometer checks, ACHS, and we will put them on a regular insulin sliding scale. We can start a cardine infusion to maintain that systolic blood pressure below 150 millimeters of mercury. We will continue his simvastatin 10 milligrams PO at night. We'll start Pepcid 20 milligrams PO BID for GI prophylaxis, and then we're also going to put bilateral SUDs on for DVT prophylaxis. Thank you.